The next presentation is from Chloé Buso. Chloé received her undergraduate degree at Queen's, and then she did a master's degree at U of T under my supervision. So Chloé, please come and tell us about your presentation on the pathophysiology and treatment of computer screen intolerance. Whoops. Thanks. Hopefully I didn't destroy it.
Okay, hi everyone. Today I'm going to be presenting a lot of my master's work where we looked at the pathophysiology and treatment of computer screen intolerance in patients with persistent concussion symptoms. I just want to take a moment to acknowledge all of the co-authors that I worked on this with. I worked with Dr. Tartaglia, Dr. Jurisica, Dr. Reber, Dr. Dalton, and as Dr. Tatter mentioned, he was my supervisor. So as Dr. Ryder mentioned earlier, there are many different types of concussion symptoms, and I guess around the world, they have different definitions. In our center, we define persistent concussion symptoms as at least 3 symptoms that persist for over 1 month. Vision symptoms have often been overlooked. Many practitioners they often they don't assess them in the clinic when people have a concussion. Headache is always the most predominant one that's analyzed. But light sensitivity and photophobia are very common concussion vision symptoms that are often on standardized concussion questionnaires. In the literature, these terms are used interchangeably, and in our view, they are virtually the same. And these can be defined as a pain or discomfort in response to light. And patients that suffer from light sensitivity tend to suffer from computer screen intolerance. This symptom can be defined as a distressful symptom that can worsen other symptoms when you're looking at a computer screen. And there are many different types of computer screen intolerance symptoms, such as headache, light sensitivity, blurred vision, double vision, eye strain, difficulty reading, difficulty concentrating. This symptom doesn't appear on any standardized concussion questionnaires, and no one seems to be looking at it. Our center is the first to look at this symptom. Computer vision syndrome has been looked at in healthy control populations. However, this symptom has not been characterized in concussion. And unfortunately, there are no ways to fully eliminate this symptom. There are some ways to help to alleviate some symptoms of computer screen intolerance, which I'll touch on later. But unfortunately, right now, there's no way to actually treat this. So before though we can talk about treatment, I want to talk about some potential pathophysiology that might be involved in this symptom of computer screen intolerance. And I have 3 potential theories that I'm going to discuss today. The first has to do with the pupil light response and pupil diameter. The second has to do with critical flicker fusion frequency. And the third has to do with the intrinsically photosensitive retinal ganglion cells. So first, I'm going to start with some neuroanatomy. As mentioned earlier, the eyes and the brain, the vision symptom is up to 40% of the brain. But during fetal development, actually, the eyes are developed from the ectoderm. So in other words, the eyes are actually developed from the brain. And so this pathway here has to do with the pupil light response. And I just want to show the complexity of our visual system. So light would enter the eye through the pupil, which goes through the retina, which then travels along the optic nerve, and then it projects to the lateral genicular nucleus. But then there's other different pathways. And so if you come back in the other direction, we have the accommodation pathway, which then goes through the ocular motor nucleus and the ocular motor cranial nerve, which controls the constriction of the pupil in response to light. So what is the pupil light response? Well, the pupil light response refers to the actual pupil constricting in response to light and dilating in the darkness. And so after concussion, if patients have a larger pupil, that means that more light can essentially enter the eye, and that can be perhaps an indication for increased light sensitivity. Another theory could be that a slowed down pupil light response can contribute to light sensitivity. However, this hasn't been proven if PLR is related to symptoms of computer screen intolerance, but this is just one potential theory. There have been a lot of research published on people looking at the PLR as a biomarker of concussion, but no one has assessed if this is actually involved in the pathophysiology of computer screen intolerance. The second theory that I'm going to be discussing is critical flicker fusion frequency. And this is defined as the lowest frequency that light is perceived to be non-flickering or steady. After concussion, something might happen to the brain's ability to fuse images. And concussion patients with computer screen intolerance may have an abnormal critical flicker fusion frequency threshold. But where does fusion of light occur in the brain? Does it happen in the retina or somewhere else entirely? I just want to walk you through the visual pathway again through another angle, I guess. So if you look at my diagram over here, light enters the eye through the retina and it projects to the lateral genicular nucleus. And then it splits into two different pathways. We have the magnocellular pathway that's shown in red, and we have the parvocellular pathway shown in purple. Magno is the Latin term for large, and so you can think that this pathway is responsible for looking at the larger details, such as the motion of light. Whereas parvo, that's the Latin word for small, and so this could be responsible for looking at the finer details, such as the color of light. It has been postulated that the magnocellular pathway might play a role in critical flicker fusion frequency because this is responsible for detecting the motion of light. However, we still do not know if critical flicker fusion frequency is the reason for computer screen intolerance. There have been studies done in the literature, but no one has achieved any significant results. The sample sizes were very small, and they included brain injuries that were more severe than concussion. The last potential pathophysiology that I'll be discussing has to do with the intrinsically photosensitive retinal ganglion cells. These cells comprise 0.2 to 2.5% of all ganglion cells, and they're located everywhere within the retina except the fovea. Both fluorescent lights and blue light, both fluorescent lighting and electronic devices contain blue light. And it just so happens that the IPRGCs are activated by blue light. If you look at the diagram on the screen, this was taken by Nozedia et al. 2019, and they looked at migraine patients who have a light-induced headache. And so they have hypothesized that the IPRGCs within the retina have monosynaptic inputs that are projecting directly to the thalamus. The thalamus is the region of the brain that's responsible for processing pain information. Now, this is intriguing because computer screen intolerance has an element of pain and discomfort in response to light. And so if these thalamic neurons are receiving monosynaptic inputs, we might be able to target them in future therapeutic interventions. However, again, this is just one hypothesis, and we do not know if the intrinsically photosensitive retinal ganglion cells are involved in computer screen intolerance. So back in 2018, our center was the first to conduct a study to evaluate a non-LCD screen as a therapeutic intervention for computer screen intolerance. And the non-LCD screen is pictured here on the screen on the left. This had no backlight or flicker, and it had a much slower refresh rate than the LCD screen. And the LCD screen, that's your conventional computer screen on the right. And so in this study, they measured the change in symptoms after a 30-minute reading task in a sample that comprised 29 patients, 79% which were female. And for the results, they did find that the non-LCD screen produced fewer symptoms. However, there were some significant shortcomings with the screen. First, the price. It was very expensive. It was around $2,000. This screen had no scrolling ability and no color. So it's also not multifunctional. Nowadays, most people have to take a Zoom call, and that wouldn't be possible using a screen like this. This brings me to the study that I completed during my master's, where I evaluated a flicker-free screen for concussion patients with computer screen intolerance. To address the shortcomings of the previous study, we evaluated two new screens that were 27 inches. These screens were identical, so the patients were blinded. They didn't know which screen they were using when they came in for their study visits. And everything about these two screens was the same. They had the exact same settings, the same brightness, the same color. The only difference between these two screens was whether they flickered or not. But you're probably wondering, what makes a flicker screen flicker? Well, this is done through pulse width modulation of an alternating current. This turns the voltage on and off at a high frequency, which induces flicker. But at a lower brightness, it induces a greater flicker, which could be problematic for concussion patients because they tend to lower the brightness if they have light sensitivity when they're using a computer screen. The flicker-free screen uses a direct current, so this provides a constant stream of light at any level of brightness, which eliminates the flicker. This flicker-free screen is commercially available. You can purchase it on Amazon for as low as $120. So the objective of the study was to determine if concussion patients with computer screen intolerance are less symptomatic after reading or watching a video on a flicker-free screen compared to a computer screen that flickers. And we hypothesized that patients with computer screen intolerance will experience more symptoms and a greater severity of symptoms while performing tasks on a flicker screen in comparison to the flicker-free screen device. We recruited 47 patients with computer screen intolerance for this study. 73% were female and 27% were male. This is an interesting finding because the previous study also had majority females. Also, Dr. Ryder's study had majority females. And so perhaps light sensitivity and computer screen intolerance are more prevalent in the female population. There's already a lot of literature out there that has established that females have more severe symptoms and take longer to recover from concussion. So perhaps this is another thing that more females suffer from. However, we have not indicated this yet, but this is just one thing that we would potentially like to look into. Or perhaps females are more compliant and willing to participate in our research. But the median age of the included sample size was 39. The median number of previous concussions was 2.5. And if you look at the breakdown of cause of concussion, the most prevalent cause of concussion was our struck by object or intimate partner violence group. And the least predominant cause was sports and recreation. Over the years, sports and recreation has always usually been the most predominant, but perhaps now more people are getting educated that there are other ways, other types of ways that you can sustain a concussion. And the median time from their index concussion to the time of their first study visit was 12 months. I'm going to walk you through some data that was collected during the pre-questionnaire. And so the following few slides were data collected prior to testing. So these are the symptoms that patients reported that they experienced since their concussion in response to using a computer screen. Everyone in our sample had computer screen intolerance, so that was the most prevalent symptom. But the next three symptoms that patients experienced in response to using a screen were light sensitivity, headache, and eye strain. This is the occupations and the return to work status of their sample. So 70% of our sample had returned to work, and of those patients, 55% of them had returned at a reduced workload. And as you can see, we have a variety of different occupations. We have administration, business, students, teachers, lawyers, but the common denominator about all of these jobs is that most of them require them to be using a computer screen daily to complete their work. This is the reported computer discomfort and average time per day spent on a computer screen. And so majority of the patients reported moderate to severe discomfort while using a computer screen. And 30% of these patients said they spend 6 to 10 hours a day using a computer screen. What I want to emphasize here is that majority of the patients are symptomatic. However, they're required to be using a computer screen to complete tasks for work or school, and they might not be able to take the time off. When we took data on types of aggravating light sources, the three most aggravating light sources were computer screens, fluorescent lights, and flashing or flickering lights. And interestingly, TV screens were actually one of the least aggravating light sources. So this is the experimental design. All patients in our study were recruited from our clinic at the Canadian Concussion Centre at Toronto Western Hospital. Patients were included if their concussion was within 1 month to 5 years of their first study visit. if they had persistent concussion symptoms, if they had computer screen intolerance, if they have the ability to speak in English so they can comprehend our consent forms and our intake questionnaires, and if they're between ages 18 to 65. And patients were excluded if they had any neurological conditions, any severe psychiatric disorders, or any major pre-existing visual disorders. Patients were recruited and consented and then randomized in either to group 1 or group 2. Group 1 used the flicker screen during their first visit and the flicker-free screen during their second visit, and group 2 used the vice versa. This is the Sports Concussion Assessment Tool, and this is a standardized concussion questionnaire that is used to assess the total number and severity of symptoms. There's a total number of 22 possible symptoms with a maximum severity of 132, and this was one of the primary outcome measures for our study. This was administered to patients at 3 time points, once at baseline, so before the reading task, again after a reading task, and again after our video. I'm going to walk you through an example of what could be expected of a participant that was in group 1 for this study. So someone from group 1 first came in and they used the flicker screen, and they first filled out a pre-questionnaire. And so the questions on this pre-questionnaire were some of the data that I've already presented. Then they filled out the baseline scat. Then they read for 20 minutes on the computer screen. Then they did the after reading scat. Then they watched a video for 10 minutes. This video had no auditory component, and it was a high quality motion video with lots of color. Then we did the post-intervention testing. Visit 2 followed the exact same procedure. However, it took place 3 to 10 days after visit 1, and they used the different screen. Someone in group 2 followed the exact same procedure as someone from group 1. However, the order of the screens that they used was flipped for the visit. When we did our statistical analysis to compare the differences in symptoms between the flicker screen and the flicker-free screen, unfortunately, we did not find any significant differences. However, if you look at the first column, that shows the symptoms in the flicker screen, and the second column shows the symptoms in the flicker-free screen. The flicker screen did yield a higher number and severity of symptoms, and the symptom severity was trending to be significant. We were pretty close. The p-value was 0.053. However, unfortunately, that is not statistically significant. And after the video task, there were no significant differences in video after the video. And this might just be because the video wasn't a cognitive task, whereas so there didn't really yield much of a change in symptoms. We did a qualitative analysis to gauge the patient's subjective responses after using the screen, and the overall consensus after using the flicker-free screen was that reading was more tolerable. I'm going to read some of the quotes that the patients said, and so many patients said they still got a headache. The screen did not cause any extreme changes in my symptoms. The screen was soothing on my eyes. It helped with concentration, and I had more energy to read. The screen felt softer while reading. The screen seemed easier to tolerate than the screen I use at home. My eyes felt less strained while reading. When we did the qualitative analysis for the flicker screen, the overall consensus was that the screen caused an uncomfortable reading experience. The screen was too sharp. I needed a softer screen. The screen was uncomfortable and caused an increase in my symptoms. My symptoms got worse after reading the screen, especially while reading. After using the screen, especially while reading. My eyes felt strained. My eyes felt pain as if I was staring into the sun. So there are some limitations with our study. The first being that the questionnaire we used might not have been the best tool to evaluate symptoms of computer screen intolerance. The SCAT, the Sports Concussion Assessment Tool, was created with the intent to evaluate acute symptoms in athletes. However, if you look back at our cause of concussion, sports and recreation was actually one of the least predominant causes of injury. The SCAT may have some irrelevant symptoms that are not relevant to the methodology of our study, and so therefore the reason we may not have gotten significant results is due to the symptoms that we were evaluating. But unfortunately, there are no questionnaires specific to measuring symptoms of computer screen intolerance. After this study, we did find some other questionnaires that are more specific to vision and could have been more useful, such as the brain injury symptom survey or the Montreal brain injury vision screen testing. However, none of those questionnaires are specific to computer screen intolerance, and they don't assess symptoms from using a screen. So what we did was we conducted a sub-analysis. And so to do that, we tabulated the most prevalent symptoms after reading on the flicker screen. And the reason we did that was because reading was our most aggravating task, and a flicker screen is a conventional screen that most patients would have when they're using a screen to do their work. And so the symptoms in black were the symptoms that were prevalent in over 50% of our sample, and the symptoms in purple were prevalent in less than 50% of the sample. And the reason we chose 50 was because we wanted to create a rule that would allow us to have a reason to eliminate some symptoms. And so some symptoms in purple are important for assessing concussion. However, they might not be the most prevalent for computer screen intolerance. And so, such as balance problems, the patients were seated throughout the intervention, so balance shouldn't be something that is affecting their computer screen intolerance. Noise sensitivity, the room was quiet the whole time, so that shouldn't be a factor. And also trouble falling asleep. Patients shouldn't be attempting to fall asleep during our study visit. So when we conducted our stub analysis and redid our the Wilcoxon match pair sign rank test, we did find a significant difference between the severity of symptoms between the flicker screen and the flicker free screen. Um, and this was when we omitted those 8 purple symptoms on the previous slide. But again, after the video, there was no significant difference in the number or severity of symptoms. So to conclude, the flicker-free screen did not significantly help patients with computer screen intolerance, but it was close. But this might be due to the limitations with the SCAT. And we found that if we refine the tool, there is a difference between the computer screens. After the video, this did not significantly affect symptoms, but this might indicate the role that cognition and attention play in triggering symptoms of computer screen intolerance. When you're watching the video, patients are more relaxed. They don't have to retain or process the information the way that their brain has to work while they're reading. Another factor might be due to the fact that when they were watching the video, patients were seated a little further back to stimulate when they were watching a TV, whereas reading they're closer to the screen. Perhaps if we had patients play a video game instead of watching a video, maybe that could have induced symptoms. But just to wrap up here, I just want to summarize what I've learned about the treatment of computer screen intolerance. And so, as I mentioned earlier, there is no way to fully eliminate symptoms while using a computer screen, but there are certain techniques that you could use or to help alleviate some symptoms. And so the first is assistive technologies. And so I have 3 examples here on the screen. So the first being f.lux or nighttime mode. This f.lux is an app you can download from the internet, and it shifts your computer screen to make it an orange tone. And it does this to eliminate the blue light, which is an aggravating light source for people with concussion. Another screen setting is dark mode, which you can do in your settings if you have an iPhone or a computer. And it shifts the text and makes the whole background dark and the text becomes white. Or you can increase your font size. If you're having headaches, perhaps a larger font size could help to alleviate some of your headache symptoms while you're reading. There's glasses. So blue light blocking glasses work to attenuate the blue light. We have color filtered glasses, such as these Elton John type sunglasses that Dr. Tatter likes to recommend in his clinic. And we have sunglasses. We recommend patients to go to the optometrist to check their prescription. We do find that patients have changes to their prescription after concussion, and so perhaps the optometrist could run some tests to figure out if that might help benefit you. We have preventative measures, so reducing screen time, because computer screen intolerance, if you work past your symptom threshold, that can worsen your concussion symptoms. And so reducing your screen time can help you create a strategy to be able to use your computer screen and take breaks. Decrease screen brightness if you have light sensitivity. Avoid rooms with fluorescent lighting or ambient light. And types of screens, we mentioned earlier the non-LCD screen, so that's an e-paper technology. If you're reading, you can try reading on a Kindle or Kobo because the e-paper technology that mimics actual paper, and because of there's no backlight, it's easier on the eyes and it helps to reduce headache. And then the flicker-free screen, although we didn't have any significant results, no one was injured during this study, and so why not try it? Thank you.
Thank you, Chloe. That was terrific. I noticed, Hannah, that you had 5 questions. I think you said 5 that dealt with computer screens. So you also recognize the importance of computer screen intolerance that your population of patients had. So do you want to be the first to ask Chloe a question?
Well, thank you, Chloe. That was indeed very inspiring. Yeah, I definitely recognize the need to assess what's behind the computer screen insensitivity or sensitivity. It's I see all the the measures that you can suggest to be able to tolerate computers better. I recognize them. We use them also in the clinic. What I was wondering, one of the points was to reduce light, for instance, and then with respect to handling light sensitivity, some would also argue that we should go the other way around, that we should actually increase the exposure and have the patients to learn to tolerate by increased exposure. I mean, that comes with both light sensitivity and noise sensitivity. That we would recommend them not to try to avoid lights, but rather to keep on exposing themselves to light. Do you have a comment on that?
I think the best thing to do is to obviously not eliminate exposure completely, because then it's going to be really hard to build your tolerance back up. But the biggest thing is to not be going past your symptom threshold. And so every patient has a different threshold that's going to cause aggravation. And so, for instance, with computer screen intolerance specifically, if you know you have symptoms that are going to be like starting within 1 hour of using a computer, the best thing to do would be to set a timer for 50 minutes. So you stop working before you know your symptoms are going to flare up, and take a little break and walk away, and then come back again after and try again. I think that's the best thing to do. So you're not like fully eliminating exposure. But also, if you go past your symptom threshold, you're just going to prolong your recovery because it's going to make you feel worse the next day.
Yeah, so it's the graded exposure that you recommend.
Yes.
Yeah, thank you.
Any other questions? Yes, Dr. Rizos.
It not only was the information really interesting, and you presented really well, with great flow. I have 2 questions. One is clinical, and then I'm going to ask permission for the second that has a geopolitical undertone that may resonate with people and our presenter here.
Oh,
Listen, I'm sure that in the OR you have confronted much more difficult things. So the first is, from a clinical point of view, what I took away, 3 things, was that the computer experience in terms of symptoms, concentration, focus, attention was improved with a flicker-free screen. But that when reading or watching a video, that there wasn't a translation to an improvement in those settings.
yes.
Would that, okay. I wonder if there might have been, or you might have explored, or there may be an interest in exploring because many of us will deal with athletes. And we will talk about the baseline relative rest being tolerable. However, even with slight increase, a fast walk, which many of the people here had sedentary jobs, but was there any look at secondary outcomes of tolerance of going up and down the stairs, walking quickly, doing their groceries?
That's an interesting question.
Yeah, that's a really great question. I am an avid athlete myself, and so I'm all for physical activity. Unfortunately, we didn't measure a patient's physical activity during this study, but that could have been something of interest to do if perhaps like seeing if they sat on the computer for 10 minutes and then they did a walk after, how would that have affected their symptoms? There's already been like papers published that have proven that physical activity can increase the BDNF, which can help to alleviate and promote recovery in concussion. But that's not something that we looked at in our study.
Yes, and so what I've noticed with the BDNF is in my experience in working with optometrists who work with athletes with prolonged symptoms is the amelioration of some of the symptoms after that, some of the visual symptoms after the optometrist intervention will allow them a greater exercise tolerance. And I have again surmised or inferenced without objective evidence that that has allowed them to get over the hump to do the exercise and to call upon the the brain's natural sequence of BNF production. So the reason I think it may be important is those people who do a lot of work on the computer screen may feel so bad afterwards that their motivation or the state that they're in may prohibit exercise. Those who are more avid athletes, those who rely on it for collegiate or national, international, professional sports would have potentially more to gain if that was something of research interest.
That's a terrific idea. We might incorporate that in our next trial. Try exercise right there. Chloe is an exercise advocate, so she could have them exercise, bring them back to the screen and see how they do.
So
That's a good idea.
Great idea, because people that are probably spending 10 hours a day are probably seated the whole time, and so they aren't moving as much, and so that could also be why they have more severe symptoms. So.
I think the Finns had done a study where they had their students before writing an exam do some low-level exercise and compared it to the control who did not. And again, it was one study, they showed an improvement or a difference in the scores in those who exercised before than after. And again, I don't know the biological plausibility. I would leave that to others, but it's an interesting thought. The other question is really a yes and no, so it's very quick, is are there either Canadian or Danish distributors of the flicker-free screen so we don't have to source an American distributor?
That's a great question. Maybe I should go back to my slide to see which other companies, because I did some research on it. And so we used BenQ for this study, but if you go onto Amazon now, it's commercially available. And so there are other distributors that are selling flicker-free screens too, other than BenQ.
In 4 days, it might be worth a bazillion
Yeah, no, I
dollars or
completely
euros.
agree that we should switch up our company.
In the current Canadian wave of buy Canadian, that's a good point.
The Danish are affected because Greenland is also on the annexation list.
Good point. Well, I think any other questions we should save for coffee time. So we're going to take a 10-minute break and comment on the screen was that, thank you for a great presentation. So that's another tribute to you, Chloe.